Well, good morning, everyone, and thank you so much to the organizers for the invitation to be here today. It's a pleasure to be here and to have an opportunity to share a little bit about the work that we've been doing and some of the advances in breast cancer care that we've seen over the past few years. So here are my disclosures. So we know that there is a rising trend in the rates of breast cancer that is encompassed by breast cancer being the most common type of cancer diagnosed in women in the U.S. and also the most common cause of cancer death among women in the U.S., with 1 in 8 women being diagnosed with an invasive breast cancer at some course during their lifetime. In 2025 alone, there were over 300,000 cases of new invasive breast cancers that were diagnosed. And also the rates of DCIS have increased. I think what is important to note is that the deaths from breast cancer have decreased, and that is in trend, and that I think is in large part due, one, to innovations in screening and early detection of breast cancer, and two, to some of the advances that we've seen in breast cancer care and new therapies that have significantly improved long-term outcomes for women diagnosed with this disease. And we know that the challenge is that breast cancer is not just one disease. It is a very heterogeneous type of cancer defined by different subtypes, traditionally defined by expression of the estrogen, progesterone receptor, and HER2. We know that the vast majority of breast cancers are in fact hormone receptor positive, HER2 negative. But even within each of these subtypes of breast cancer, we are finding further ways of characterizing or subgrouping breast cancer to identify targetable targets within each type of breast cancer for actionable therapies. And in terms of what's new, there have been many new drugs that have been approved over the past decade for the treatment of breast cancer, and we're going to touch base on a few of these today. You heard yesterday a little bit about CDK4/6 inhibitors. There are also novel endocrine therapies that are emerging, including oral selective estrogen receptor degraders, therapies that target the PI3 kinase pathway, antibody drug conjugates, and also immunotherapy now approved for the treatment of breast cancer that is triple negative. So we'll start with CDK4/6 inhibitors, and as we think about the treatment algorithm for hormone receptor positive, HER2 negative metastatic breast cancer, where these agents are currently approved, they are considered the standard treatment for most patients diagnosed in that first line setting with HR positive, HER2 negative advanced disease. So endocrine therapy in combination with a CDK4/6 inhibitor is the standard approach, and after that, our choice of second-line therapy in the HR positive setting really depends on the results of somatic next-generation sequencing testing. And here you can see summarized some of those first-line studies with CDK4/6 inhibitors for hormone receptor positive advanced breast cancer. And importantly, with palbociclib, ribociclib, and abemaciclib, FDA approved in this space. The only of the 3 CDK4/6 inhibitors that has demonstrated to significantly improve overall survival was ribociclib in the MONALEESA-2 and MONALEESA-7 trial, the latter for women with premenopausal women with HR positive, HER2 negative breast cancer. But taking that one step further, we also have 2 of these CDK4/6 inhibitors approved in the early stage setting. So both abemaciclib and ribociclib are approved for women as adjuvant therapy, women diagnosed with high risk early stage hormone receptor positive, HER2 negative breast cancer, and that has been based on the statistically significant improvements in invasive disease-free survival when adding these CDK4/6 inhibitors to endocrine therapy. But the question is, can we design better CDK4 inhibitors? And there are many that are on the horizon, including, for example, atirmociclib, among others, that are selective CDK4 inhibitors that may potentially have more potent activity and also spare some of the toxicity that we see with combined CDK4/6 inhibition. And we've seen some initial promising data with these more selective CDK4 inhibitors. So more to come. But as we alluded to earlier, beyond our standard endocrine therapy options of aromatase inhibitors and fulvestrant, there are now new endocrine therapies on the horizon, including oral estrogen receptor degraders. So selective estrogen receptor degraders, or so-called SERDs, are an oral formulation of these medications that are aimed to degrade selectively the estrogen receptor and have shown particular activity in those patients with ESR1 mutant hormone receptor positive, HER2 negative breast cancer. So those about 40 to 50% of hormone receptor positive breast cancers in the advanced setting who have emergence of an estrogen receptor mutation. And there are different oral SERDs that are currently in developed. The only one that is now FDA approved, currently FDA approved, is elacestrant, but we've already seen data for some of the other SERDs in phase 3 trials. And so briefly reviewing some of the data from the Emerald trial that led to that approval of elacestrant, you can see here, this was a randomized phase 3 trial for women who had received 1 to 2 prior lines of endocrine therapy in the advanced setting, at least one of those in combination with a CDK4/6 inhibitor. And patients were randomized to receive either standard endocrine therapy alone or to receive the novel SERD elacestrant. And what was striking in this trial was that, in fact, that elacestrant outperformed standard endocrine therapy in those patients who carried an ESR1 mutation, as shown on the Kaplan-Meier curves on the right. There is no overall survival advantage to date, but we do await also data from some of these SERDs in an earlier line setting and more follow-up. But I think this does highlight the importance of next-generation sequencing testing for patients diagnosed with hormone receptor positive breast cancer and detection of emergence of an ESR1 mutation over the course of the disease. And there are different ways to test for these mutations, either in tumor tissue or with liquid biopsies. And liquid biopsies have really emerged as a new way for serial monitoring throughout the course of metastatic disease. And that has become particularly relevant, as we saw at ASCO just last month, results from the SERENA-6 trial. So this was a study in the first-line setting for hormone receptor positive, HER2 negative breast cancer patients, really aiming to test whether during that first-line therapy of aromatase inhibitor plus a CDK4/6 inhibition, if detection of an ESR1 mutation and switching treatment at that time to an oral SERD could outperform continuation of standard hormone therapy until radiographic progression. So in essence, does switching therapy based on biomarker detection improve outcomes compared to waiting until radiographic progression? And in SERENA-6, the primary endpoint was progression-free survival. The study met that primary endpoint with an improvement in PFS with that switch to an oral SERD called camizestrant in combination with a CDK4/6 inhibitor versus continuing their standard endocrine therapy and CDK4/6 inhibitor. However, I think what is important is to note is not just PFS2, but not PFS1, but also PFS2 and long-term outcomes in terms of overall survival. So in essence, does switching earlier matter versus doing the switch later on in these patients with ESR1 mutations? And there is a trend favoring camizestrant for PFS2, but we await overall survival data. But I think more to come, and this is in essence, a new way of potentially tracking these emergence of ESR1 mutations and may potentially have implications for treatment selection in the future. We also saw at ASCO results from the VERITAC-3 trial. And VERITAC-3 compared a novel endocrine therapy, here vepdegestrant, which is a PROTAC, to fulvestrant in patients who had received prior endocrine therapy. And similarly, in patients with ESR1 mutations, the PFS was improved with vepdeg compared to standard fulvestrant. So many new endocrine therapy agents on the horizon, and we await data for combination of these new endocrine therapies with some of the targeted therapy approaches that we utilize in the HR-positive setting, such as CDK4/6 inhibitors or agents that target the PI3 kinase pathway. And I think this is important because we also know that about 40% of hormone receptor positive HER2 negative breast cancers carry alterations in the PI3 kinase pathway. That is activating mutations in PIK3CA, AKT1, or inactivating mutations in a gene called PTEN. And we know that that promotes signaling and independent of estrogen in ER-positive HER2 negative metastatic tumors. There are currently 3 agents that are FDA approved that target the PI3 kinase pathway. The first approved was alpelisib in combination with fulvestrant for patients who have PIK3CA mutant HR-positive HER2 negative breast cancer after progression on endocrine therapy. And that was based on the results from the SOLAR-1, where there was a significant improvement in median PFS. On the right, capivasertib is also approved for patients who have alterations in the pathway. So that is PIK3CA, AKT1, or inactivating alterations in PTEN. And that was based on the data from the Capitello 291 study shown here on the right. I would note that there are some differences. So both studies demonstrated significant improvements in median PFS, but there are differences in the patient population where you can see that in SOLAR-1 there were very few patients who received a prior CDK4/6 inhibitor, and near 70% of patients in the Capitello study had received prior CDK4/6 inhibition, which reflects our current practice in that first-line setting. The third PI3 kinase targeting agent that was most recently approved is inavolisib, and that was based on the INAVO120 trial. And this approval is in a patient population that is considered higher risk because of endocrine resistance. So these are patients who have a known PIK3CA mutation and have recurred essentially within their progression during or within 12 months of having completed their adjuvant endocrine therapy. And here in this study, patients were randomized to receive either fulvestrant and palbociclib with placebo or inavolisib, and the study, its primary endpoint was PFS, which was met in this trial. And also there is an improvement in median overall survival with the addition of inavolisib. So I think this stresses the importance of doing targeted NGS testing for patients in the first-line setting with HR-positive breast cancer for detection of these alterations, PI3 kinase pathway alterations for those patients who may be a candidate for Inavo in that high-risk setting, or for capivasertib or alpelisib later on, and also ESR1 mutations for the oral SERD. I do think it's important to note some of the toxicity that these agents carry, and in particular, you can see here some of the differences in terms of hyperglycemia, higher with alpelisib and inavolisib, and important also to monitor very closely for this, and sometimes use of prophylactic anti-diabetic regimens are needed. Also, rash and diarrhea are common with these agents. Now, switching gears from hormone receptor positive HER2 negative breast cancer to triple negative breast cancer, we know that for patients with metastatic TNBC in the first line setting, the choice of the recommended regimen in that first line setting really hinges on the results of PD-L1 testing. Where for patients with PD-L1 positive tumors, currently the standard of care is chemotherapy in combination with an immune checkpoint inhibitor, pembrolizumab, and for patients with PD-L1 negative tumors, chemotherapy or a PARP inhibitor for patients who carry germline BRCA1 or 2, or one might add also PALB2 mutations are options. Now, the approval of pembrolizumab, the immune checkpoint PD-1 inhibitor for TNBC, came from the Keynote 355 trial. That was a randomized phase 3 study that compared in the first-line setting for patients with PD-L1 positive triple negative breast cancer, PD-L1 defined as a CPS cutoff greater than or equal than 10 using the 22C3 assay, and randomizing patients to receive chemotherapy or chemotherapy plus the immune checkpoint inhibitor. We saw in this trial that the addition of the immune checkpoint inhibitor significantly improved not only median PFS, but also median overall survival when added to chemotherapy in that subgroup of patients, the about 35 to 40% of triple negative breast cancers in the metastatic setting that are PD-L1 positive. And taking that one step further, for early stage triple negative breast cancer, pembrolizumab now is also approved as neoadjuvant therapy in combination with chemotherapy, and then as adjuvant therapy after surgery. And that was based on the significant improvements in pathologic complete response, event-free survival, and now more recently we've also seen improvement in median overall survival with the addition of pembrolizumab to standard chemotherapy. But beyond immune checkpoint inhibition, there's much interest in studying other strategies, learning from our colleagues from hematology, from hematologic malignancies also, really a lot of interest in new immunotherapy approaches, including adoptive cellular therapy. So whether that is adoptive transfer of TILs or CAR T cell therapy, there are different strategies that are currently under investigation with interesting targets as well for breast cancer. And specific to PARP inhibitors, which we mentioned as well, There are currently 2 PARP inhibitors that are approved for women with advanced HER2-negative metastatic breast cancer who carry germline BRCA1 or 2 mutations. These 2 PARP inhibitors are olaparib and talazoparib, and they are approved based on the improvements in the phase 3 trials noted here, Olympiad and Embraca, respectively, where the PARP inhibitors improved median PFS compared to standard chemotherapy, a physician's choice. And importantly, not only did they improve median PFS, but also quality of life. And you can see here that in terms of the time to deterioration of global health scales and quality of life, outcomes significantly favored the PARP inhibitors over standard chemotherapy. And beyond germline BRCA1 or 2 mutations, which we see in about 10% of women living with advanced breast cancer, there also is benefit from these PARP inhibitors in patients who carry germline PALB2 mutations. And these are data that were presented at ASCO last year from my colleague Dr. Nadine Tung at Beth Israel. This was from the TBCRC 048 trial, the olaparib expanded study, looking at the activity of olaparib in patients with germline PALB2 mutations, showing a high response rate here of 75%, and also some activity in patients with somatic, not germline, but somatic BRCA1 and 2 mutations. And also taking this one step further from the advanced setting to the early stage setting, olaparib is also now approved for women with germline BRCA-associated high-risk early HER2-negative breast cancer, and that encompasses both HR-positive and triple-negative breast cancer, with significant improvements in invasive disease-free and overall survival with treatment with 1 year of olaparib in the adjuvant setting for these patients. But I think that if there is one class of drug that has significantly changed the treatment landscape of breast cancer over the past decade across breast cancer subtypes, that would be the antibody drug conjugates. There are currently 4 ADCs that are approved for the treatment of breast cancer, 2 targeting HER2, trastuzumab emtansine or TDM1 for patients with HER2-positive breast cancer, trastuzumab deruxtecan or TDXD for patients with HER2-positive metastatic breast cancer, or HER2-low or hormone receptor-positive HER2 ultra-low tumors, which we'll talk about in a minute, and then 2 ADCs that target TROP2, datopotamab deruxtecan or Dato-DXd for metastatic HR-positive HER2-negative breast cancer, and sacituzumab govitecan or SG, both for triple-negative and HR-positive HER2-negative breast cancer. And so starting with the HER2-positive space, as we think about the current treatment algorithm for advanced HER2-positive disease, note that the standard for many years has been the Cleopatra regimen of a taxane plus dual HER2 blockade with trastuzumab and pertuzumab. But after progression on THP, the standard second-line regimen over the past few years has been trastuzumab deruxtecan based on the DB03 data. But importantly, this is changing as we see data evolving from these ADC trials in a less pretreated setting. And at ASCO, again, just a month ago, my colleague Dr. Sarah Taleni presented results from the Destiny Breast 09 trial. And this was a phase 3 study in the first-line setting for advanced HER2-positive breast cancer, looking at TDXD with or without pertuzumab versus the standard THP regimen for first-line HER2-positive metastatic breast cancer. And results from the TDXD plus pertuzumab arm were were presented at ASCO, and TDXD plus pertuzumab versus THP significantly improved median progression-free survival. You can see here a delta in the median PFS of almost 14 months. We await additional data from DB09 in terms of overall survival and also data for the TDXD monotherapy arm. But I think we are seeing a shift as these ADCs position themselves as preferred initial cytotoxic regimens across different breast cancer subtypes. And interestingly, we're also seeing some evolving data for new HER2 ADCs, bispecific antibody drug conjugates, for example, such as zanidatamab zovodotin and others, showing very promising anti-tumor activity, also in the first-line setting, and phase 3 trials that are ongoing or planned to look at these agents as well in that setting. Beyond HER2-positive breast cancer, one might ask, well, why would you utilize a HER2-targeting ADC in patients with HER2-negative breast cancer? And that is because the classification of HER2-negative breast cancer has also shifted in recent years. We now have ways of further refining that classification of HER2 status. We know that we can further divide HER2 negative breast cancer into HER2 low, ultra low, and null tumors based on degree of expression of HER2, because we know that some tumors have some degree of HER2 expression, just not enough to be called HER2 positive. And HER2 low is now defined as tumors that have IHC 1+ or 2+ staining without amplification by ISH, and about 60% of hormone receptor positive HER2 negative breast cancers are in fact HER2 low, and about 40% of triple negative breast cancers are HER2 low. And this is relevant as we saw data from the DESTINY-Breast04 study, which compared T-DXd to chemotherapy of physician's choice in women with advanced HER2 low breast cancer who had received prior endocrine therapy if HR positive and 1 to 2 prior lines of chemotherapy for advanced disease. And this study met its primary endpoint of a significant improvement in median PFS in the hormone receptor positive HER2 low patient population, and that was about 90% of patients enrolled on the trial. Also, there was a significant improvement in median overall survival with T-DXd compared to chemotherapy. And you can see also in the column in the middle that all patients in the intent to treat population, there was also significant improvements favoring T-DXd. And in an exploratory analysis for T-DXd in the triple negative, in essence, hormone receptor negative HER2 low patients on the far right, there also were numerical benefits favoring T-DXd compared to treatment of physician's choice. And taking that one step further, DESTINY-Breast06 evaluated T-DXd in a less pretreated setting. And these results were presented last year at ASCO by Dr. Corigliano. DB06 included patients with advanced hormone receptor positive, HER2 low, or ultra low tumors who had received prior endocrine therapy and no prior chemotherapy for metastatic breast cancer. And one might ask, well, what is HER2 ultra low? So HER2 ultra low is faint or incomplete membrane staining in up to 10% of tumor cells. And so in DB06, both patients with HER2 low and ultra low tumors were eligible for participation. And this study met its primary endpoint with a significant improvement in median PFS in the hormone receptor positive HER2 low patient population, as shown in the top left-hand corner. And there were also similar numerical benefits in the HER2 ultra low group, as shown in the top right-hand graph. On the bottom, median overall survival, which has not reached statistical significance. Additional follow-up is ongoing, but I would caution that as T-DXd is now a standard option approved for patients with HER2 low and now also ultra low hormone receptor positive breast cancer, there are patients in the control arm who could have received and did receive the ADC after participation on the study. And how that might confound the effect of overall survival remains unclear. Beyond HER2-directed ADCs, there are 3 TROP2-directed ADCs that are for which we have seen phase 3 data. 2 of these approved, sacituzumab govitecan and Dato-DXd. You can see here some of the differences across these TROP2 ADCs in terms of the monoclonal antibody. They all target TROP2, which is highly expressed across different tumor types, including different breast cancer subtypes. All 3 of these ADCs, similar to T-DXd, carry a topoisomerase 1 inhibitor as the chemotherapy payload. There are differences in terms of the half-life and drug-to-antibody ratio that translate into differences in the schedule of administration of these agents. And sacituzumab govitecan was approved for the treatment of metastatic triple-negative breast cancer based on the results from the ASCENT trial shown on the top. This study enrolled patients with pre-treated advanced triple-negative breast cancer and compared SG to chemotherapy of physician's choice, showing not only a significant improvement in median PFS, but also a near doubling in median overall survival in advanced triple-negative breast cancer. And on the bottom, TROPiCS-02 demonstrated significant improvements in HR-positive, HER2-negative pre-treated disease, both for PFS and OS favoring SG. For datopotamab deruxtecan, we await data from phase 3 studies in the first-line triple-negative space. In HR-positive, HER2-negative breast cancer, TROPION-Breast01 showed a significant improvement in PFS compared to chemotherapy with Dato-DXd. And finally, we're seeing some emerging data for SAS-TMT, another TROP2 ADC for which there are several phase 3 trials that are ongoing, both in triple-negative breast cancer and hormone receptor-positive HER2-negative disease. I think very important as we see these antibody drug conjugates across the board in metastatic breast cancer and studies ongoing for early stage disease as well, that we highlight the toxicity profiles of these agents. You can see the relatively high rates of neutropenia with some of these agents, often requiring growth factor support, in particular with the TROP2 ADCs. Also GI toxicity, including diarrhea, nausea, and vomiting. These ADCs cause alopecia, which is also an important consideration. And then there are special adverse events of special interest that are important to highlight, such as interstitial lung disease or pneumonitis, which has been reported with the deruxtecan-based ADCs, with fatal events having been reported, thus highlighting the importance of promptly identifying any respiratory symptoms and educating patients on reporting any respiratory symptoms on these agents, stopping therapy if the ILD is suspected, initiating promptly steroids, and diagnostic workup. We've also seen stomatitis and ocular surface toxicity with datopotamab deruxtecan and SAS-TMT also reported. And for these, prophylactic mouthwash and eye drops are actually recommended at least 4 times a day while on therapy. Now, as one might imagine, in triple-negative breast cancer and other breast cancer subtypes, there is interest in evaluating how we can further improve outcomes with these antibody-drug conjugates. And there are strategies looking at these topo-1 inhibitor-based ADCs in combination with immune checkpoint inhibitor, including in the first-line metastatic triple-negative breast cancer setting. Both TB05 and ASCENT-04 are looking at TROP2 ADCs in combination with immune checkpoint inhibitor versus that current standard KEYNOTE-355 regimen that we reviewed earlier of chemotherapy plus pembrolizumab. And in fact, from the trial on the right, ASCENT-04, results were presented at ASCO by Dr. Taleni just last month. And this study met its primary endpoint of progression-free survival, showing a significant improvement in median PFS with SG plus pembrolizumab versus chemotherapy plus pembrolizumab. Median OS remain immature. There appears to be a slight trend favoring SG, but I think what is also very important to highlight about this study is that in the control arm of chemotherapy plus pembrolizumab, the study offered the option of crossing over to receive SG at time of progression. And so how that might impact, again, overall survival results remains unclear. But what is striking is the significant improvement in median PFS, the hazard ratio favoring SG, and if this obtains regulatory approval, this regimen will move to the preferred first-line space for metastatic PD-L1 positive TNBC. For those patients who are not candidates for immune checkpoint inhibition in the first-line setting, who would otherwise receive chemotherapy or a PARP inhibitor, there are several phase 3 trials looking at TROP2 ADCs in the first-line setting compared to standard chemotherapy, and we eagerly await results from some of these trials that will be likely presented in the near future. And as one might imagine, with these different ADCs that are now approved and with different overlapping indications, as many of these have, there are several questions that remain unanswered, including one, how do we optimally select the initial antibody-drug conjugate for patients who are candidates for more than one, but also for those who may be able to receive more than one, if and how should we sequence these ADCs? And to help address these questions, we are conducting the TRADE-DXd trial at Dana-Farber. This is being run through the Translational Breast Cancer Research Consortium. This is a large phase 2 study looking at the sequencing of TDXd and at time of progression Dato-DXd or vice versa in patients with metastatic HER2-negative breast cancer. So finally, just in the last few minutes, I wanted to highlight some of the efforts and bring to you some of the research that's ongoing in the Breast Oncology Center at Dana-Farber Cancer Institute in Boston. At the Breast Oncology Center, we really are a multidisciplinary team with now more than 30 medical oncologists, 9 surgeons and 3 radiation oncologists, as well as a group of radiologists and pathologists who are dedicated specifically to breast cancer. We also have an advanced fellowship in breast oncology with fellows, with trainees from different countries around the world. And within the Breast Oncology Center, we have different specialized programs that provide both clinical resources and also research initiatives, from a triple-negative breast cancer registry that I've had the honor of working with my colleagues to develop at Dana-Farber, and that is a multi-center registry, to the inflammatory breast cancer program, the Young and Strong Women that Dr. Ann Partridge leads, also older adults with breast cancer, so specifically a program for women with breast cancer at elderly age, lobular breast cancer, and breast cancer in men programs that are currently in development. We're really trying to capture the breadth of different areas of investigation across the board. And as far as the research infrastructure, there are different teams that are working together, both from a clinical trials program perspective, also our cohorts and these programs that I just mentioned that also focus on biospecimen collections and analysis of samples, tissue, blood samples that are collected as part of different research projects. We have a translational hub led by Dr. Middendorf and Dr. Talani that helps with the collection of all of these samples and also navigating several of the different correlative analyses that we plan for these trials. A biostatistics core, and also computational biology, which I think is of utmost importance now also as we're interrogating these samples and the data that are collected with novel technologies. And from a clinical research perspective, Drs. Erica Mayer and Ada Wax lead our clinical research program with a breadth of different breast cancer trials open for all subtypes of breast cancer, all stages. We also have participated actively in several clinical trials that have led to FDA approvals for agents, as noted here. And beyond clinical interventional therapeutic research, the cohort studies, prevention and diagnostic studies, also integrative medicine trials are ongoing. Dr. Ting Bao recently was recruited to Dana-Farber Cancer Institute and has really built a program focused on integrative medicine strategies for patients with breast cancer, and in addition to that, supportive care studies as well. And I think really trying to bridge the science into with the clinic, not just our clinical investigators and clinicians and laboratory scientists work together, but we work very closely with patient advocates. And there's a wonderful group in the Breast Oncology Center of patient advocates, specifically in breast, who we work very closely with on many of our research initiatives. From an infrastructure perspective, there are new technologies that are being developed, as you're well aware, with liquid diagnostics in breast cancer, circulating tumor DNA, as we talked about earlier, even potentially using ctDNA in earlier stages of disease as well, and much research that is ongoing, in addition to the efforts focused on artificial intelligence for discovery and prediction. And this is all possible thanks to different partnerships with cores across the institution and different Harvard-affiliated institutions, as shown here. All of this with the goal of trying to personalize treatment, improving the way that we tailor therapy for patients, in addition to optimizing drug dosing and combinations to enhance outcomes for patients living with breast cancer, and also a lot of interest in understanding what are the mechanisms that drive resistance to these agents, how can we overcome those mechanisms of resistance, and can we identify predictive markers of toxicity to these agents to help mitigate side effects that are associated with these therapies. So I hope with all of this, that there's much progress that is being made in the field of breast cancer, many reasons, lots of reason for hope. And my key takeaway messages here are that with these recent approvals of new therapies, again, many with overlapping indications, I think it has become imperative to understand how to optimally select and sequence agents. And we need to conduct trials that can help us address these questions. There are many new endocrine agents, targeted therapies, ADCs, immunotherapy approaches in development, as we've talked about today, and many others that, due to time, we're unable to dive deeper into, but much on the horizon. And understanding the mechanisms that drive response and resistance to treatment is key to help inform treatment strategies, including optimal combinations, sequencing, and duration of therapy. So with that, I'd like to thank you all very much for your attention, and I'm happy to take any questions.